Hello friends, my name is Dr. Ansham Aneja Arora. I'm a practicing pulmonologist in Gurugram and I'm here again with another read aloud of a highly requested topic this time, MDR TB guidelines. So the guidelines that I'm reading out for you today were published in March 2021. These are the latest changes in management of drug-resistant TB in India, and they are all approved and in accordance with the WHO recommendations. So they pretty much reflect what is the latest in management of drug-resistant TB. Let's get started. So this guideline is a downloadable format. You can download it from tbcindia.org. It is a 300-page document with around 9 chapters. The initial chapters focus on the epidemiology, on managing diagnosis, what is the flow of the diagnostic algorithm in a programmatic setting and all, and then it talks about the treatment and the diagnostic tests and special conditions. I will be focusing on diagnosis and treatment today. So let's start with the common definitions that we must know. We already know that MDR TB is TB which is resistant to INH and rifampicin both. Whether or not there is additional resistance to other drugs, INH plus rifampicin both, if they are resistant, then it's MDR. What is a presumptive DR TB patient? Any patient whom we suspect to have resistance will be called a presumptive DR TB patient. At the moment in our program, all patients must be subjected to testing for drug-resistant TB. So all patients are eligible for testing for rifampicin resistant at time of diagnosis, or if you find them positive during the treatment, or they are lost to follow-ups, or they are treatment failures, and both adult and pediatric patients, any non-responders, they are presumptive drug-resistant TB patients. What is a pre-extensive drug-resistant TB patient or pre-XDR patient? If a patient has rifampicin resistance either solely or is an MDR TB, and in addition to that he has resistance to fluoroquinolone, then there is a chance that this patient might develop or have XDR. So then if fluoroquinolone gets added, then it becomes a pre-XDR. And here, let's jump here to XDR. This is a new change, a new definition from what we used to study many years ago. And what has changed is that if a patient has MDR or rifampicin resistance, and addition fluoroquinolone resistance, levoflox or moxiflox, and at least one additional group A drug, out of which presently either bedaquiline or linezolid or both, because these are available now across the country. So MDR or rifampicin resistance with fluoroquinolone and one additional group A drug will be called XDR or extensively drug resistant TB. So this is a major change because now we have kind of phased out injectables from managing MDR TB. So we are not using injectables or aminoglycosides in a definition for XDR also. And coming back to something that we have left middle, the polydrug resistant TB. If any more than one of first-line TB drug is resistant, other than a combination of INH rifampicin, because that will make it as an MDR, then we can call it polydrug resistant TB. What is rifampicin resistant TB? Anywhere you find resistance to rifampicin, whether in an MDR, with an XDR, or mono or poly, you can label it as RR-TB. So it's a big problem now, and where we stand now in 2020 is that our plan is to end TB by 2025, and so we have got NAAT included, true NAAT included, and there's a nationwide coverage of universal DST, of DELAMANID introduction, and we are focusing on shorter and longer oral MDR TB regimens. So injectables are really out of the consideration now and in future to come. So how do you detect resistance? So my talk is split into two, detection and treatment. So we are here in the first part, and I'm trying to make it as simple as possible. There are two methods to detect drug resistance. One, a rapid test, and two, a culture based test. So if it's a rapid test, a DRT, drug resistance test, you can use respiratory specimens here. You can use non-respiratory specimens like biopsies in saline. You can use culture isolates. You can use FNACs and centrifuge them, and all can give you a rapid diagnosis. And the second is growth-based test, which require cultures. So in the rapid test, we also call them as genotypic tests. NAAT is the most frequently available test in addition to LPA. So NAAT can be CBNAT or XPERT MTB XDR. So CBNAT is XPERT MTB RIF test. It detects resistance to only rifampicin. We also know it by the name of GENOTYPIC test here. So GENOTYPIC test detects TB. So it tells us if TB is positive, and it also tells us if rifampicin is resistant. So only rifampicin resistance is told in this test, and it is based on RPO-B gene mutation. Results are quick. You can get the results in 90 minutes from the lab. What is new is that the same XPERT MTB test is now also being introduced in XDR format, and this is something which is new. It is awaiting WHO endorsement. It is already approved, and it will now be used as a follow-up test. So if a patient has rifampicin resistance, then probably the same sample can be used for XPERT MTB XDR, and we can also know on point whether he has MDR XDR TB. The other test which is now being included is TrueNAT MTB and works on similar principles of CBNAT. And the fourth, which is widely being used now, is a PCR based line probe assay test. The other group of testing is growth based test. We all know about solid culture LJ medium testing. Well, in programmatic management, it is now being discontinued, and we are totally switching to automated liquid cultures, also called as MGIT, which detects mycobacterial growth as fluorescence or BACTEC tests, and these are the preferred tests. Let's come to the newer test, XPERT MTB MDR. Just one slide on this test. It's also PCR based. It gives rapid test results. It can be used on already existing machines if they are equipped with 10 color modules. So it will be incorporated pretty soon. And in addition to rifampicin resistance by XPERT MTB RIF, this one will give us resistance data on isoniazid, on ethionamide, on fluoroquinolones, as well as injectable aminoglycosides. Line probe assay test is one of the most frequently utilized tests, which can give us information on both first line drugs as well as second line drugs. This is easily available. Most labs are doing this test, and you can have results on rifampicin, INH, fluoroquinolones, and second line drugs as well. If the test says that rifampicin RPO-B resistance is detected, it means rifampicin is not going to work. If the test mentions a CAT-G mutation, then INH is not going to work even at a high dose. So CAT-G, maybe you can remember as CAT-G is really high, so INH is not going to work. But if it is just A, okay, so INH A resistance is of low level, so here INH at high dose is likely to be effective. But remember that if INH A resistance is detected, then even ethionamide is not going to work, because ethionamide resistance is through INH A. In the instance of fluoroquinolones, we can detect GAR-A and GAR-B gene mutation. If GAR-A mutation is there, then levoflox will not work, but moxiflox can work at a high dose, right? And if it's GAR-B mutation, then even if it's A or B, nothing matters. Levoflox, moxiflox will not work if it's GAR-B mutation. In second line injectable drugs, we can get information on aminoglycosides, and they will likely not be effective, and then we can use the culture methods to guide our treatment choice in the treatment arm. What is the scope of LPA? So LPA detects mutations to R, H, fluoroquinolone and second line agents also. But so far we do not have any rapid molecular tests which can detect ethambutol or pyrazinamide resistance. So we can still not rule out the role of growth based tests. So here comes growth based tests, and in India we are having quality assured growth based DST to H, R, Z, fluoroquinolone including moxiflox and levoflox individually, linezolid, amikacin, kanamycin and capreomycin all across our country. Testing for clofazimine also has been introduced in phased manner and it is being made available, and our reference labs and the national level labs NIRT and NITRD also have DST to bidaquilin and delamanid, and then this is going to be expanded soon to other labs. Also, the work has already started in 2021. This is another modality which is new and it deserves mentioning. It's called genetic sequencing or gene sequencing. Gene sequencing is the most advanced form of resistance testing, and it can be used when reliable DST is not available. So where we are not able to subject patient specimen for cultures, we can send them for genetic sequencing, and this also gives us the flexibility to modify a patient's drug regimen individually in case of multi-resistance. So phenotypic DST, which is performed in MGIT, can still miss certain mutations, and for these disputed mutations a genetic sequencing may be helpful. Genetic sequencing is also called as targeted next generation sequencing (NGS), and it gives a rapid diagnosis of drug resistant TB through targeting sequences and mutations. The techniques used are pyrosequencing, Sanger sequencing and NGS. So all the genomic variants which predict drug resistance phenotypes can be detected. You can detect the strain lineage, you can use it for surveillance, and you can also detect genetically related strains so that we can stop the transmission in families and in clusters. Still not incorporated on a large scale basis, but individual laboratories are already doing this. In the programmatic management, they are still preparing a library of the genetic sequences and of the various strains. Until that happens, it will not be included in program, but this is available now. Let's come out to lab turnout time, and we as practitioners must know when to expect the results. So we all know that solid cultured LJ medium used to take 3 weeks average for smear positive patients, and they used to wait for 8 weeks for smear negative patients. This is an egg based medium, not so widely used now. Liquid cultures are being used more, and the automated ones are being preferred. They can give a result in 8 to 10 days in a smear positive sample, and it may take 2 to 6 weeks if the smear is negative. Bactec MGIT is the name, and it's an automated cultured method. It has slightly more contamination being a liquid culture, and so that is the only issue here. Phenotypic DST or the liquid medium culture sensitivity report. So once the culture grows the bacteria in 10 days or within 2 weeks, then it is subjected to sensitivity testing, and it may take up to 3 weeks from a positive culture to get the report. If you're sending the sample for LPA line probe assay, you can get result in as soon as 1 to 3 days, and if it's a smear positive patient, then you can directly send it for LPA. If it's a smear negative patient, then first the sample will be taken up for culture, and from the culture isolates, then LPA will be applied. So the labs will always tell you that only if the smear is positive, we will be taking your requisition for an LPA, and if the smear is negative, only after culture comes positive, LPA will be done. In terms of CBNAT, XPERT MTB RIF, as I told, 90 minutes is usually the time, so turnaround time is 2 hours, and it's also a fully automated assay. In TrueNAT, which uses quantitative real-time RT-PCR, 1 hour time is enough for detection of TB and an additional 1 hour for rifampicin resistance detection, because it's a two-step assay, and so first it will detect TB and then it will process for rifampicin, right? And in rapid tests, we also have some immunochromatographic tests, which if you perform on a solid or a liquid culture growth can give you results in 15 minutes for rapid identification, and these are commercially available. So let's come to the second half quickly. We are already 15 minutes into the session, into the video, and we have to shoot into the treatment now. So treatment is based on testing, right? So if it's genotypic testing, we get faster results. So CBNAT, TrueNAT, LPA can help us guide a treatment very quickly. And based on these tests, we can initiate our treatment. Once we initiate our treatment, we can follow it up with an LPA, and we can also see for resistance with second line agents and fluoroquinolone. So that is how a rapid treatment for drug resistant TB can be started. If we are dealing with cultures, then based on the group of the medications, we can test them. So amongst group A, culture will give us results for levoflox, moxiflox, bedaquiline, as I said, in some centers, and linezolid. For amongst group B, clofazimine is being added, and group Z, DELAMANID is being increasingly added, and we can get results for pyrazinamide and aminoglycosides. So this is a very important algorithm of diagnosis and treatment. So remember, all TB patients have to go for NAAT. So GENEXPERT or NAAT testing for all TB patients. In program, there are 2 specimens that are to be taken. The first specimen will be tested at the site. So all presumptive TB patients, all known TB patients, all non-responder, all failures, everyone should first undergo NAAT. Now, if you detect rifampicin resistance, then this arm starts. And in this arm, if there is resistance to rifampicin, we want to know whether there is resistance to other second line drugs and INH also. So to know that, one specimen or the second specimen will be sent for LPA of first line, LPA for second line, and for liquid culture. So this way we can get information for resistance of INH, pyrazinamide, bedaquiline, clofazimine, moxi, and linezolid. This second specimen in program is sent to a culture and sensitivity lab. Once the LPA, first line, second line, and cultures have been sent, we do a pre-treatment evaluation to see that the patient does not have any contraindication or exclusion criteria for any specific medication. If there is any contraindication or exclusion criteria is met, then patient cannot be taken for a short regimen, right? After completing this evaluation, if there is no additional resistance detected, we get back the LPA result in 3 days, and it says that there is no resistance, or it mentions that there is an INH resistance which is detected with CAT-G or INH-A, either of them, but not both. Why not both? Because then we cannot give him the shorter regimen, we have to go to a longer regimen. So even if it's an MDR, but CAT-G or INH-A, one of them mutation is there, and there is no fluoroquinolone resistance, so it's not a pre-XDR patient, then we can start him on an oral bedaquiline containing shorter regimen of MDR or rifampicin resistance TB. And if we see that there is an additional resistance on starting treatment, as which comes by the culture reports, or patient is not tolerating the drugs, or any of these drugs are not available, then this patient has to take a longer regimen, oral regimen, and it will be further modified based on the results, for which a replacement table is provided. So this is one arm of the patient. In the other arm, if the patient had rifampicin resistance and we detected INH resistance with both. So the term that really needs emphasis here is both CAT-G and INH-A, and or we are also detecting resistance to fluoroquinolone. That means this patient is not eligible for a short regimen. He has to go for a longer regimen. Now, this is for patients who are resistant. What if our patient is drug sensitive? So if our patient is drug sensitive, we still send a sample for an LPA if he's sensitive to rifampicin, and if the LPA now detects INH resistance, we treat him as H-mono or poly-drug resistant TB regimen. What I have frequently seen is that if rifampicin is not resistance, we do not go ahead and try to find out resistance for other drugs. This has to change. So even if rifampicin is sensitive, do an LPA, see if INH is resistance or not. And if INH resistance is there, we have to treat it for H-mono poly-DR TB regimen. And that if shows non-tolerance, then we modify it. If the patient does not have INH resistance, the perfect scenario is a drug-sensitive TB patient, then we just go on with the drug-sensitive TB regimen, right? And then we don't need to check him specifically for other medications. And for each patient whom we detected to have INH resistance, automatically we have to go and test him by doing a second line LPA, by doing a liquid culture, and then we can take the call later. So treatment starts based on LPA and the treatment modification is based on culture. Have a look of this algorithm. It's very easy to understand and very elaborative, and most of our treatment dilemmas can be solved with this. It's available on page 25 of the document and can be seen. So, how do we interpret the results? Once we do our LPA and NAT, now we realize that NAT and LPA are one of the initial tests. What if your NAT and LPA first line are discordant? So NAT says that rifampicin is resistant and LPA says it's not resistant, or vice versa. Then you must repeat the NAT. You must repeat the NAT at a culture and DST lab level, and then finally come to a conclusion. If INH-A mutation is detected, then remember, then ethionamide will be resistant. If your first line LPA is done on culture isolate, if your patient is smear negative, then we have to use other exclusion criteria till the time LPA is available and decide the regimen, whether we can initiate a shorter regimen or not, because LPA will not be available to you in the first 3 days. So for all other patients, we start the treatment based on LPA and we modify later. Who are the patients who are outrightly excluded from a shorter regimen? Patients who had an exposure of second line agents for a month. Then we have to start longer regimen. If in a patient resistance is not detected to INH or fluoroquinolone, then we can switch them to shorter once we kept them on a longer regimen based on the first line and second line LPA. But remember, they should not have consumed second line agents for more than a month. So these are the exclusion criteria for the shorter bedaquiline regimen. The first, as I said, is that if he's had an exposure to second line agents for more than a month, we will not start shorter regimen. If he's intolerant to a drug or there is a risk of toxicity from a drug, we will not start bedaquiline regimen. If it's highly extensive TB, bilateral cavitary diseases, extensive diseases, and especially in children less than 15, if there are cavities and bilateral disease, we will not start a shorter regimen. For severe extrapulmonary disease also, like miliary, TB meningitis and CNS TB, longer regimens have to be started. And for children less than 15 years, in extrapulmonary form other than lymphadenopathy, shorter regimen will not be started. Pregnant and lactating women and less than 5 years are contraindications for shorter regimens. Let's go to a situation where rifampicin resistance is detected. We now are able to have a predetermined flowchart in our mind. We will perform first line LPA, we will perform second line LPA if available. If it's a new case and there is no risk of drug resistant TB and we get a positive report of rifampicin resistance, we can retest the patient. No need to jump to conclusions of rifampicin resistance based on your NAAT if there is no risk of drug resistance. If MTB detected is very low, there are chances it could have been false positive. Repeat, retest and then decide. As I said, if LP and NAAT come discordant, do a second NAAT at a culture lab and decide. If it's a smear positive patient, send for direct LPA. But if it's a smear negative patient, send for liquid culture and then on liquid culture, do an indirect LPA. In case of patients where fluoroquinolone resistance is not detected, so it's not going towards an XDR, and H resistance is either of the genes, then give him shorter regimen. But if there is a resistance to both the genes, then give him a longer regimen. How about the second arm? Let's quickly revise. If rifampicin resistance is not detected, still do a first line LPA for H. Discordant report, do a second NAAT. No H resistance, just give him drug sensitive TB regimen. And if H resistant, then give him the treatment according to H mono or poly DR TB regimen. So how do we go with the flow? If it's a suspected patient, take one early morning and spot sample. The first sample to be sent for NAAT. If NAAT says that TB is positive, whether or not it's rifampicin resistance, you send the specimen number 2 for LPA to a culture lab. For all smear positive patients at culture lab, first line, second line LPA has to be applied and liquid culture has to be done. But if they are negative, smear negative, then do a liquid culture and later do an LP. And all the samples are to be sent in triple layered packing and cold chain has to be ensured. Let's talk about extrapulmonary samples now. In extrapulmonary sample, this is very important that we have to collect our specimens in a sterile saline. So if it's lymph node, if it's biopsy material, if it's fluid, if it's a lavage, you have to collect in sterile specimen. No preservative is to be added and definitely formalin is not to be added. If you want to send your specimen for histopathology, you divide it in 2 tubes and send it as soon as possible. CSF specifically is to be sent within 4 hours, and for this sample we can do a NAAT, and even for FNAC we can centrifuge and do a NAAT even at the facility of collection. For gastric lavage, it has to be centrifuged at lab, lymph node, and for FNAC everything has to be homogenized, so it has to be centrifuged in a lab, and following centrifugation the testing can be done. What is the turnout time expected? So if you've sent these samples, we've already noted the turnaround time expected. So within this time frame, we can expect to take a decision. Let's come to presumptive MDR TB in children and just a small mention of this. So even in children, if there is no response, poor response, loss to follow-up, exposure to a drug-resistant TB case or an MDR case or recurrent TB relapse, then you must suspect drug resistance. And this is the algorithmic approach for children. So if it's a childhood TB patient and we know that there is a drug resistance, we have available data, then it's a confirmed case and we start treatment. But if we do not have the report of resistance, then we find out if this patient had contact with an infectious patient. If he had a contact and the source was resistant, then we again reattempt to do the sensitivity if it was negative, and we again test for drug resistance even if it requires bowel sample. Still no information, cannot get the test, and the source case was a drug resistance, you treat him as a probable resistant. If the patient had a contact with an infectious patient and you know that the DRT DST of source patient is not available or he had drug sensitive TB, then again try to do a DRT testing of the source specimen or child specimen. If resistant, treat. If not resistant, then follow up as a DSTB patient. So let's refine the treatment protocols. The medicines or the anti-TB drugs available for managing MDR TB and resistant TB have now been divided into 3 groups. Group A, Group B and Group C. Group A and Group B are our prime groups. So in all regimens, we would like to include all the 3 Group A drugs plus add one or both of medicines in Group B. Group C drugs are like reserve drugs. So we use them only to complete our regimen if some of these cannot be given or these are resistant, as in an XDR case, and when medicines of Group A and Group B cannot be used. So what are the medicines in Group A? These include number 1 fluoroquinolone, levoflox or moxiflox, number 2 bedaquiline and number 3 linezolid. What are the Group B agents? Clofazimine, cycloserine or terazidone. What are the Group C agents? Ethambutol, DELAMANID, pyrazinamide, imipenem, or meropenem, aminoglycosides like amikacin or streptomycin, ethionamide or prothionamide, and PAS. So Group C agents are optional agents which can be added to the regimen. Main drugs are fluoroquinolone, bedaquiline, linezolid of Group A and clofazimine, cycloserine of Group B. So what is the longer regimen and what is the shorter regimen? Longer regimen has a total duration of 18 to 20 months. There are no separate IP or CP now, so it is the same. At least 4 of the total TB agents have to be started initially. So as I said, 3 in Group A and 1 of Group B can be done, and at least 3 have to be included for the rest of the treatment once bedaquiline is stopped. In India, all 5 drugs can be started from Group A and Group B, and we continue with 4 drugs beyond the first 6 months or 8 months. If patient has taken long regimen for more than a month, he cannot go into shorter regimen even after the LPA or culture reports. So this is how the long regimen looks like now, 18 to 20 months, of which levoflox and bedaquiline for 6 months or longer, along with linezolid, the Group A, and clofazimine and cycloserine from Group B, which will be continued further. Linezolid, once continued after 6 months, the dose will be tapered to 300 mg. Bedaquiline is given only for 6 months. So once the initial phase is over, the patient will stay on linezolid, bedaquiline. So linezolid, bedaquiline and levofloxacin initially amongst Group A, and after 6 months bedaquiline goes away and patient stays on levofloxacin, linezolid along with the cycloserine as well as clofazimine. Pyridoxine needs to be added for all patients, and for pre-XDR patients the treatment goes more to 20 months. That is the maximum duration of treatment. At 6th month, patients are reviewed based on the 5th month culture result. IP can be extended for a month, but there is no provision of extending the continuation phase. What cautions are to be exerted? Cardiotoxicity seen with bedaquiline and clofazimine. Specifically, QTCF prolongation. So baseline ECG and serum electrolytes are very important. If your QTC corrected interval is between 450 to 500 milliseconds, a cardiologist consultation is needed. Linezolid causes, we know, anemia, thrombocytopenia, peripheral neuritis and optic neuritis, specifically anemia, thrombocytopenia, very important to monitor. Cycloserine to be used carefully in seizure disorders and depression patients because it can cause suicidal tendency. Clofazimine causes dark brown discoloration of skin. Please tell your patient that this is going to happen and counsel him. Other drugs which can be used as reserve drugs but not highly recommended include kanamycin and capreomycin. So amongst aminoglycosides, amikacin and streptomycin is preferred. They have been found to have poorer outcomes with these patients in the past. Gapifloxacin and high-dose INH are to be avoided unless needed. Thiacetazone is also now almost phased out. Clavulanic acid should be included in the regimen as a companion to carbapenems, imipenem, cilastin and meropenem when they are given. Let's come to bedaquiline or BDQ. Its function is to target the mycobacterial ATPase synthase. So this enzyme supplies energy to TB patients. So we are depriving it of energy and we are giving him a strong bactericidal and sterilizing activity. This drug has a beautiful extended half-life. So this drug still stays in plasma up to 5.5 months post stopping bedaquiline. And so treatment with bedaquiline is stopped at 6 months and not continued for the rest of 6 to 8 months. Bedaquiline is now well incorporated in our regimens, in our standard regimens for TB patients. How about DELAMANID? DELAMANID is also a first approved drug in nitrodihydroimidazoles. It's a bactericidal drug and it has a very interesting mechanism of action. The first thing is to block the synthesis of mycolic acid, so the building blocks will not work, so the bacteria will not create more, and then it also poisons the bacilli with nitric oxide, which it releases when it's metabolized. So DELAMANID is group C, still not a group A agent, but it can be used. This is the treatment algorithm for MDR TB now. So once rifampicin resistance detected, we know what should we do next. We should send the second specimen at the culture lab for first line, second line, LPA and liquid culture. We must evaluate the patient. If there is no additional resistance, we start him on shorter regimen if there are no exclusion criteria. But if there is INH resistance with both CAT-G-INH, A and fluoroquinolone resistance, then he has to take the longer regimen. Exclusion criteria we just went through in previous slides and we make sure that they are first ruled out. What are the inclusion criteria for short regimen? So if he has RR resistance or has MDR with INH-A or CAT-G mutation, or he has MDR or RR TB with fluoroquinolone not detected. That is the criteria. Other inclusion criteria, 5 years and above can be given bedaquiline, no history of exposure to previous treatment for more than a month, there shouldn't be extensive TB, and non-pregnant ladies. What evaluation do you need to do before treating the patient? Amongst the labs, check for blood sugar, HIV testing, complete counts, LFTs, TSH levels, urine, electrolyte, UPT test for females, chest x-ray and ECG for QT prolongation. So this is how the shorter regimen looks like. The duration will be 9 to 11 months. It's a completely oral regimen. First 6 months bedaquiline is included. After 6 months bedaquiline is taken off. Levoflox, clofazimine. In shorter regimen, pyrazinamide, ethambutol, INH high dose and ethionamide continue. But for the next 5 months, levoflox, clofazimine, pyrazinamide and ethambutol are given. So let me again mention this because it's different from the longer regimen that we had read about earlier. In the shorter regimen, 9 to 11 months treatment will be given. Since this patient are not resistant to fluoroquinolones, remember levoflox will continue throughout. Bedaquiline will go on for the first 6 months. And since these patients can be just MDR or rifampicin resistant, so there is INH in high dose, pyrazinamide and ethambutol, so rifampicin is out, and ethionamide. So initial phase is of 4 to 6 months. 4 months initially, it can be extended up to 6 months, and a continuation phase is of 5 months. So total 9 to 11. Remember that when you're giving the shorter oral bedaquiline regimen, at the end of 4th month, bedaquiline, levoflox, clofazimine, pyrazinamide, ethambutol, high dose INH and ethionamide are there. From 5th to 6th month, if the IP is not extended because of culture positivity, then bedaquiline will continue. From the start of 7th month to 9th month, only 4 drugs remain: levoflox, clofazimine, pyrazinamide and ethambutol. So here, if you take notice, then ethionamide has been dropped out from 5th to 6th month, and the rest 1, 2, 3, 4, 5. These drugs remain, and INH and ethionamide are dropped out. So let me say it again. First 4 months, all these agents 1, 2, 3, 4, 5, 6 and 7 drugs. From 5th and till the end of 6th month, we have 1, 2, 3, 4 and 5 drugs, and from 7th till 9th month we have 4 drugs. So it's 7, 5 and 4. If the IP is extended up to 6 months, then bedaquiline, high dose INH, ethionamide, all 3 are stopped together at the end, and the duration of CP will be 5 months. Exclusion criteria is, since it's bedaquiline, clofazimine, so patient should not have arrhythmias, patient should not have QTC interval issues at screening, or Torsades points, or heart failure, or electrolyte issues. There is also a shorter injectable regimen, although injections are being tried to be phased out. However, if injectable is to be given, then it includes high dose moxiflox instead of levoflox, kanamycin, amikacin as a replacement to bedaquiline, ethionamide, clofazimine, pyrazinamide, high dose INH with ethambutol remains. For 5 months later, moxiflox, clofazimine, pyrazinamide and ethambutol will continue. So let's count the drugs: 1, 2, 3, 4, 5, 6 and 7 again. So bedaquiline is being replaced with kanamycin, amikacin, levoflox with moxiflox, and the rest is the same. And here again moxiflox instead of levoflox, and the rest remains the same. Because we are using kanamycin and amikacin, audiometry has to be done baseline in every 2 months, and creatinine has to be checked. These are the doses which are given according to the weight band, and this table is easily available and you can note them. What are the list of the drugs that are to be avoided? Because bedaquiline has a lot of interactions. Antiemetics, analgesics, even antacids are safe to use, but domperidone, tramadol, pantoprazole are to be avoided. We also have to avoid loratadine here, although we can give cetirizine as an antihistamine. Amongst antimalarials, chloroquine, antibiotics like Ciplox, Norflox, cotrimoxazole, metronidazole to be avoided. Antifungal specifically has a very high interaction. Anti-epileptics have to be taken into consideration. Diabetes medicines can be given, and statins are very important to be avoided. Antiarrhythmics have an interaction, so dose adjustments may be needed. Amongst antiretrovirals, anxiolytics, antipsychotics and antidepressants, also there is a group of medicines which should be avoided when bedaquiline is used. Adverse effects, as I said, QT prolongation with bedaquiline, fluoroquinolone and clofazimine. Any drug can cause rash, any drug can cause GI symptom. Etonamide especially causes diarrhea, psychotic symptoms, clofazimine also, suicidal tendencies, seizures and tendinitis with fluoroquinolones. And other than that, hepatitis, as in first line TB drugs, giddiness, thyroid issues, depression, they are all common. So this is a very good list given in the guideline statement. This is just a nutshell of how we can explore, we can go on with the treatment and diagnosis. There's still a lot to be explored and there's still a lot in the guidelines that can be further seen. So I invite you to explore more. There are specific indications, specific conditions. There are replacement tables which have been given and they all can be seen in this guideline statement. Please leave a comment in the comment box if you would want me to cover the rest of the part, then I can do that. And happy reading, and I hope I've made drug resistant TB at least slightly more understandable for us. Thank you.